Thank you so much, Nandi, for that wonderful rendition of what you do best. Ladies and gentlemen, I'd like to take a moment to briefly share with you why we are gathered in this place. Between the year 2016 and 2019, I was privileged to serve as the Permanent Secretary in the Ministry of Health. During that time, we received data on a monthly basis that was loaded with information about the state of what was happening on the ground in the country. One thing stood out very clear from the data that was coming from the National Bureau of Statistics, that the maternal mortality in Tanzania stood at 556 per 100,000 live births. Those are the women that were dying. That converted into actual nominal numbers would amount to about 20,000 women. Now, the numbers that were coming were not reflecting that to be the fact. But none of us denied the fact that there were women that were dying as they brought other lives to this world. We got to work to get to know the reason. Now, we discovered a few things. The first one was the fact that many rural places did not have adequate infrastructure for health. And so this led to women being taken long distances to seek for such services. But even when they met to those facilities, human resource for health and health commodities were not adequately provided for to intervene. And so we sought funding to improve the situation, including bringing up the infrastructure. More rural health facilities were built and were appropriately equipped to provide for the needed intervention for the women that had those problems. Her Excellency mentioned in the video that we just saw the CMOC interventions. But that was not the only one that we had in mind, or the others that would have benefited from the surgical intervention. While this was taking place, more human resource for health had to be developed, so more people got trained, while at the same time, the government that is very sensitive to the need of its population employed a few others to bridge the gap. It was a very good start, but we still had a long way to go. And when Her Excellency, President Samia Suluhu Hassan, became our leader in the year 2021, I was confident that more progress would come, because prior to her ascension to the office, I had heard, and the majority of us must have followed, she was sharing stories on what she witnessed, and those of her close relatives, if not friends, insisting on the importance of quality midwives' care to pregnant women. And she insisted it was because these midwives would be tasked with the responsibility of breaking either good news or bad news to those women that went to them for services. Thank you so much, Your Excellency, for sharing such stories and for your leadership, in which we see very clearly that maternal child health was a priority among many other things. To talk more about this progress is a group of experts who have been on the front line of this change. Please welcome to the stage our moderator, Dr. Rasa of Gates Foundation.
Thank you, Mpoki. I'm nowhere as talented as Nandi, but thanks for just using my first name. Dear all, it is a pleasure to be here today to celebrate some of the gains that Mpoki just discussed and learn more about how this came to be in Tanzania. Maternal mortality is often discussed as being an indicator of the health system itself. It is a complex process, making sure that a mother gets treated early in accordance with what her needs are, in a program that integrates nutrition, in a program that cares for her as well as for the developing baby, and all to make sure that the beginning of life goes as it's supposed to, with joy, with celebration. We've heard of the tremendous progress that has been made in Tanzania over the past several years. We understand also the path that lies ahead, the opportunity to bring additional innovations, improvements in the community, connections across the health system to continue this pace of achievement. I'm here to welcome to you 3 experts that have been on the front lines of not only generating the evidence that has been critical for the successes here in Tanzania, but also globally, who have helped understand what some of the challenges have been in terms of implementation of various aspects of this transition, whether it's comprehensive emergency obstetric care, improved referrals, improved identification of risk, or improved newborn care, or integration with nutrition. The first is Dr. Ahmad Mukwani, the Director of the Division of Reproductive, Maternal, and Child Health in Tanzania's Ministry of Health. Dr. Mukwani has been in the Ministry of Health for 13 years, where he has been involved with or led many of the programs that we will discuss and hear more about today. Dr. Sunday Domenico, who's been the Program Director of Thamini Uhai for over a decade. Thamini Uhai means value life, which is central to the work that we're all here to do. He's also the President-elect of the Association of Gynecologists and Obstetricians of Tanzania. And also Dr. Mary Sando, the CEO of the Africa Academy for Public Health, leading efforts to ensure that scientific research and our latest understanding of what is critical to making this progress is implemented in policy and practice. I welcome the panelists up to the stage. Dr. Mukwani, panelists, welcome. I'm honored and privileged to have you here. My first question is for you. We've heard about the progress that has been made. You've been central to guiding much of that process, being involved with it. Please share with us a little bit, what are the factors that you have seen as critical to making this progress?
Thank you very much for inviting me to share my experience, mitigations, coordinations, and the level we have attained. First of all, I was asked to lead the section by then of the productive and child health to be an assistant director. And that was a way back 2018. By then, when I was joining, I was like, would I manage? That was the first question. But the first thing that I saw was we needed to have a political will. We need to have a kind of political will. And fortunately, I've been working with this area for quite some time. So the first thing was to start a campaign, which was called the Jiongeze Tuavushe Salama campaign. And I struggled with my PS, with my minister, and I remember by then the PS was Dr. Mpoke. Let us launch this thing. So we managed to get Her Excellency Dr. Samia. By then she was the Vice President, to be our guest of honor. And to be sincere, when we went to her residence to brief about this, she was saying it's a good thing. And one of the questions the challenge she put it forward, she said, we have to do it. We need to save mothers and children. And she said also that the newborns, I'm told that they are dying. So that was a start. And she signed a contract with the regional commissioners as well. And to be sincere, after the launch of Jiongeze Tuavushe Salama, our sailing as a ministry, as a sector, was easy because you could see the budget allocation for the sector, for the health sector, was going upwards. By then, I think it was standing somewhere around 1.8 trillion, and now we are talking about 2.4 trillion. And to be sincere, I would associate this rise in budget allocation because once we started Jiongeze campaign, everything was like sailing up. So I would say that was a starting point. The second thing was Mpok tried to elude on that area. The services, because the evidence says you can reduce maternal mortality and under 5 mortality only and only if people can access services. 80% of the population can access services within 5 kilometers. And to be sincere, after raising this budget, we saw everything again multiplying. The numbers are multiplying. Now we are talking 530 health centers are able to provide the cesarean section services. That means the services are now reaching there to the people in need. But the other component that we fixed was, we expect annually to have at least 360 complicated cases. For maternal, for example, 360 cases are complicated, 15% of the population of pregnant women. So those who are in the urban settings, they will enjoy the specialized care. But those who are in the grassroots level, they will end up with the general practitioners. And sometimes general practitioner says, I've offered everything, I can't offer more. So with the ministry leadership, we were able to start these groups. It was like a little play. And from those groups, WhatsApp groups, it was simply WhatsApp groups, we grew into a workable telemedicine. And one of the publications will see that in the first year when we started that service, we managed a total around 500 cases, which were critically ill women, and only 4.6% of those women died. But if we did not take this specialized care to the grassroots level by using innovation, I don't think those women can survive. And now it has grown to be a habit in all regions, whereby you see the regional leaderships making sure that all their facilities are connected within the network. Over time, with the permissive environment, political will, and here I emphasize political will, we were able to do a rigorous review. And this we started when Madam President became the full president from 2021. When we started, we said, is it possible? Let us try. We started reviewing very stringently to every maternal death and every newborn. Stringently we review through the Zoom review. And yesterday, I'm happy to say that the minister was part of the reviewers. She participated. And the other ministers who were passing through this sector as well, they participated. Through those accountability mechanisms we put in place, we saw more cases are attended adequately with specialized care. Evidence are used to transform the health sector so that it can mitigate various challenges. So in short, I would say, one is political will. Secondly, make services available close to the people. And here the coverage is 80%. And thirdly, use the little available resources to reach the underserved population. I submit it to you.
Thank you for that energetic account of what it's taken. We saw some of this actually just yesterday when we had the pleasure of discussing with you and Honorable Minister in terms of the progress that has been made, and saw the meeting live actually. Many of the from around the country, many of the different doctors calling in, and honorable minister sharing some of the approaches that we can take. It's great to see that come. Dr. Sunday, we come to you for the next question. You've been thinking about this challenge and trying to scale up particularly CMONC services. During that experience in Western Tanzania, what surprised you the most in terms of what you learned implementing those services that stood out for you?
Thank you very much, Dr. Raza, and our guest of honor, Your Excellency President of the United Republic of Tanzania, senior delegates here, and all the invited guests. I'm very honored and humbled to be on this panel. It's a momentous occasion that I think will really give us the impetus to race toward SDG 2030. Now, come back to your question. The work that you are referring here is the program to reduce maternal mortality that was implemented in Kigoma, a 13-year program that started in 2006 and all the way to 2019. It was led by the government of Tanzania, the driving seat, and supported by Bloomberg Philanthropies, H&B Aja Group. And we worked very closely with the Ministry of Health for technical guidance, and as well as the President Office, local government authorities, and the other key partners. Why I'm setting this stage is because this program was successful in a way that we are talking about this today, because we had a very guided enabling environment. My boss and mentor here mentioned about the political will. It was really a political will walking the talk that really we need to reduce maternal mortality. And this will was not actually just spoken. It was translated into a number of policy as well as implementation commitments. We are aware of the National Development Vision 2025, which actually is ending this year as we are developing another development vision. If you read that development vision, clearly prioritizing reproductive maternal services, actually calling for 75% reduction of maternal mortality. And then we had the health sector strategic plans, and the subsequent guiding document was the National Plan, Accelerated Plan for Reduction of Maternal Mortality. And this was the working document. If you read that document, it clearly states that Tanzania was required to reduce maternal mortality from 578 to 193. And this was looking at a very ambitious target by 2015. So the interventions which have been articulated in that document include scaling up comprehensive emergency obstetric care services. And it required that by 2015, it would have covered 50% of the health centers to have CMOC, 80% of hospitals to provide the CMOC, and 70% of the dispensaries to be able to offer the required services. Now, beyond this, the policy environment that I've described, what really made this program successful, the idea was conceived from the local community, from the local doctors. And allow me to mention the late Dr. Mbaruku, God may continue to rest in peace. He conceived this idea that if you look at the geography of Kigoma, for those who have been to Kigoma, you look at the Lake Tanganyika shores and everything. There are communities that are to negotiate 18 hours along the lake shore to be able to reach to Maweni for comprehensive emergency obstetric and newborn care. Imagine you have a postpartum hemorrhage, a woman bleeding, you have a ruptured uterus, you have obstructed labor. It is impossible. Certainly this will be another registered death. So from the initiative by Dr. Mbaruku, and with this policy environment very supportive, the program was able to work with the local governments, guided by the Ministry of Health, to scale up comprehensive emergency obstetric care, reaching over 16 health facilities. And the dream was really to have the facilities with a minimum of two hours from the neighboring community to be able to reach this care. And this was made possible over the course of implementation. By the time the program was coming to an end in 2019, we had about 61% of the communities could actually deliver in facilities we were providing CMOC services. But also, as a result of this, we had facility deliveries going all the way to 80%, which was almost double from the time the program started. As a result, maternal mortality declined by 43%. We had also neonatal mortality declining. And the reason we are connecting this program essentially gave us a lesson that it's really feasible to bring care from high-level hospitals to the health centers. And the ministry was there to listen. We had a lot of forums, including the Big Disaster Now Lab, for those who remember 10 years ago. I was very lucky to be invited here, and we had a lot of critical discussion with the experts, including Dr. Makwani and others. Thus, let's explore this. Let's make this work in the context of Tanzania. And the rest is story that we are hearing here. Beyond that, we had a very good, robust monitoring evaluation. Data, the power of data. You know, if you're implementing a very good intervention, a very good program, if you do not measure the progress that you are making, it is almost useless because you don't know where you're making the right direction. So here we had the U.S. Center for Disease Control and Prevention, which was leading the evaluation. And being a technical lead in that, I was always in my toes. I know CDC, at the end of the year, they come back and ask me why facilities are not offering CMOX. So always you work with the data, work with the local facility, local experts, trying to advance this work to further heights. And finally, if a key lesson that I would advocate further, this program was so much guided by evidence. We can have very good interventions, but if you're just trying, testing every time, it was guided by evidence. We all know that majority of maternal mortality would come from the big five that are contributing about 70%. And to be able to take care of them, you need availability of quality. Key quality is very important. Quality emergency obstetric and newborn care. So we had a very robust quality improvement initiative, including clinical audits over the complications, the maternal death, and everything that essentially help us to work with the healthcare providers in the facility to refine the work that we do, to ensure that when women come to the facilities, they really receive the quality of care that is needed. On the same thinking, we understand that postpartum hemorrhage is the leading cause of maternal mortality, not only in Tanzania, even globally. In Tanzania, we count about 33% of all the maternal deaths from PPH. So here, we had a very commendable global evidence coming out. The woman trial, which actually advocated for use of antifibrinolytic for the prevention of and the management of postpartum hemorrhage. So the program worked with the government at that moment it was not in the national guidelines, but we made a decision that if WHO is recommending this very strongly, the evidence is there, then we scaled up the use of TX in the facilities, and then that initiative came to the level of the ministry. It was captured in all the relevant guidelines, and the rest is the story again. So, rather, I'd be able to explain a lot more, but I think time is very limited. The key message here is you have to have the right enabling environment, have the clear concepts developing from the grassroots, have the right people take it forward, and most importantly, please ensure you are scaling up evidence-based recommendations. Thank you very much.
Thank you, Sunday. As a student of learning more about the maternal and newborn health field from the Gates Foundation, really understanding what has led to that implementation, prioritizing local needs and grassroots is critical, and it comes through in your story. Mary, the evidence point was underscored by Sunday. You've been at the forefront of generating much of that. In fact, Tanzania as a country has been the site for many of the most transformative studies in this field, whether it's on multiple micronutrient supplements, on low-dose calcium, on the MOTIVE trial or tranexamic acid. I'd love if you could share a little bit of your experience of how do we take the best of that evidence that is being generated and implement it into policy? What are the challenges? How do we overcome those?
Thank you very much, Rasa. So in terms of looking at evidence, I would start by saying context is crucial in shaping health priorities and policies in any country. But of course, locally generated evidence is essential in forming those policies and priorities. For instance, when you look at epidemiologically, not only do health challenges in Tanzania differ from those in other parts of the world, but also the feasibility and adoption of solutions also vary globally. Citing an example, we all know that the World Health Organization recommends calcium supplementation during pregnancy. However, high costs dosing complexities, and logistical challenges have hindered adoption of such life-saving interventions in many countries, including here in Tanzania. But fortunately, as you have noted, Raza, we have evidence from Tanzania that has been done by Tanzanian institutions, including the Africa Academy for Public Health, Ifakara Health Institute, and our Muhimbili University of Health and Allied Sciences, in collaboration with Harvard University. Scientists demonstrated that the provision of a single low dose of 500 milligram calcium daily is superior and is as effective as the recommended 3 doses in the current WHO guidelines in prevention of preeclampsia and preterm birth. This evidence, homegrown here in Tanzania, is currently being used to help see how we can bring this intervention to pregnant women in Tanzania. We hope that we can pave a way and many countries can also follow. But looking back again, in over 40 years, the standard care for antenatal services has been provision of iron and folic acid to pregnant women. But again, evidence, including research studies done here in Tanzania by our own researchers, has also demonstrated that the provision of multiple micronutrient supplementation, which includes iron and folic acid, together with 13 other essential micronutrients, is superior to provision of iron and folic acid alone in preventing stillbirth, preterm birth, and low birth weight, which are really predisposing reasons for neonatal mortality. And therefore, again, this speaks about the importance of ensuring that our own evidence can really be used to advance and improve our guidelines. If I speak of mainly 2 issues here, is challenges on implementation of existing guidelines, such as the ones that we have contributed to building the evidence, and the WHO has given this recommendation. The second point I would like to touch upon is on the importance of testing different innovations. It is important that we are able to be part of testing these interventions and ensuring that in the process we have the confidence with the data to be able to say, why not as a country, confidently that we've been able to advance these efforts for scaling up for a much more impactful improvement, especially of the SDGs, maternal, neonatal, and child mortality. Thank you.
Thank you, Mary. We're going to go to just one final question for each of you on the panel to keep us on time. One of the path ahead is between now and really trying to reach the 2030 goals. What advice do you have to all of us gathered in the room, policymakers, implementers, organizations? What is it that we should be doing differently between now and 2030 in order to accelerate, continue to make this progress, and reach the goals? Your advice on what we should do differently. Dr. Mukwani, I'll start from you, and then from each of you, please.
Thank you very much, Raza. And one of the things that I would say as a way moving forward, concentrating resources. In this world whereby we have government resources and partner resources, we have seen that sometimes we have some challenges in terms of making sure that all the resources really target the last person in the rural area. And we have seen some of the projects whereby they've changed from giving partners, instead the government becomes a center of implementation. The value for money, you can account it very, very easier. And I speak this with the passion, saying that if all the resources were real targeting this Tanzanian, we would have attained most of the goals early enough before 2030. For example,